Thank you very much for the invitation to give a presentation on the neuromechanisms underlying freezing of gait in Parkinson's disease. My name is Jorik Nonnekes. I do work as a consultant in rehabilitation medicine at the Center of Expertise for Parkinson and Movement Disorders, the Radboud University Medical Center in Nijmegen, the Netherlands. And as a clinician, I do see a lot of people with Parkinson's disease and disabling gait impairments, and this is also the main topic of my research. As I'm the first speaker of this session, I would like to start with a brief introduction of the type of gait impairments that can be seen in people with Parkinson's disease. So typically, Parkinson's disease starts with continuous gait impairments, so gait impairments that are always present. And in the beginning, these gait impairments are very subtle, but as the disease progresses, these can be more pronounced. And the full spectrum involves a stooped posture with increased flexion at the trunk, increased flexion at the hips and at the knees. There's a reduced arm swing, which is typically most pronounced on one side of the body. There are short shuffling steps, and the gait pattern has a narrow base of support. Well, as the disease progresses, in addition to those continuous gait impairments, episodic gait impairments may also emerge. And these include gait fascination and freezing of gait. And during freezing of gait, people do have the feeling that their feet are suddenly being glued to the floor, as shown in this video. And freezing is often provoked by gait initiation and turning, as shown in this patient. Well, freezing is often very disabling for people with Parkinson's disease. It's difficult to manage for clinicians, and it's also difficult to grasp for researchers. And one reason for this is that there seems to be different subtypes of freezing of gait. There are different subtypes when we look at the phenotype, so how freezing of gait looks. Freezing can present as trembling in place, so alternating leg movements with a frequency of about 3 to 8 hertz. It can present as short, rapid steps on the spot. And finally, there can be akinetic freezing, during which no movements are observed at all. There are also different subtypes when we look how freezing is provoked. It can be provoked by motor triggers, such as turning, gait initiation. It can be provoked by limbic triggers. We see often that people freeze more when they are anxious or under stress. And finally, there are cognitive triggers. So freezing is typically more common when people with Parkinson's disease have to perform a dual task. So for example, talk while walking or counting while walking. Finally, there can also be subtypes when we look at the response to levodopa. So when freezing emerges, it's typically responsive to levodopa. So there is less freezing when people are on medication, but higher dosages are needed when the disease progresses. And in the end, freezing might become resistant to levodopa. Partly this is pseudo-resistance, so the dosage of dopaminergic medication cannot be increased any further due to dose-limiting side effects. In a small percentage of patients, freezing is induced by dopaminergic medication. And these people typically walk better at night when they go to the bathroom compared to walking during daytime. Well, I'm asked to give a presentation about the neuromechanisms in the freezing of gait. And the truth is that we do not completely understand how freezing of gait emerges. But let's start with looking at control of gait in healthy people. So there's not one spot in the brain that is responsible for the control of gait, but gait is rather due to a whole network of brain areas that work closely together. So when we look at the spinal cord, there are spinal pattern generators, and these spinal pattern generators are involved in the production of stepping movements. But in order not to fall, those stepping movements need to be combined with anticipatory postural adjustments, and areas in the brainstem, in the midbrain, are responsible for integrating those anticipatory postural adjustments with the stepping movements. And then, very importantly, there's also the basal ganglia, the cortex, and those cortical striatal loops are involved when the gait pattern needs to be adapted. So when we need to walk faster or slower, when we walk in a crowded environment, when we start walking, when we walk through a doorway. So typically, those circumstances during freezing of gait is seen. Well, we know that freezing can also be seen in other conditions than Parkinson's disease, and also in conditions where different areas of the brain are affected. So, like the control of gait, freezing of gait is not due to dysfunction of one spot within the brain. It's rather due to dysfunction of the whole network. And the latest ideas are that the gait network, is more vulnerable in people with Parkinson's disease, and that some circumstances, those can be motor circumstances, limbic circumstances, or cognitive circumstances, those lower the threshold for freezing to develop. And when there's neural integration failure, so when the whole network collapses, then freezing of gait emerges. So knowing that freezing of gait is due to network dysfunction, I would like to highlight 3 exciting ideas developments. And the first one relates to the question whether there's only one network that controls gait, or whether there are multiple slightly different networks. And this is in fact an exciting idea, and this is inspired by observations and stories from people with Parkinson's disease. So this is one observation. This is a person with severe freezing of gait, but he's able to climb the staircase without any problems. This is one observation, but over the last years we have collected many of those observations. So some people walk better when they walk at the rhythm of a metronome, or when they copy the gait pattern of someone else. And we were able to identify 58 unique strategies, and we have classified them into 7 categories, which may have overlapping mechanisms. And I think that there are multiple networks to control gait, or gait patterns, and that by using those tricks, people do not use the primary network that frequently fails in Parkinson's disease, but make use of other networks that still function well. So this is an important lesson for people with Parkinson's disease, that they can use tricks to overcome their gait impairments. As a researcher, I'm also interested how the control of gait is being changed when using such a compensation strategy. And we are currently investigating this in our Gait lab. And this is a person with Parkinson's disease who walks with an EEG cap on his head. And using this EEG cap, we are able to record brain activity of the cortex. And we have asked him and other participants to walk under different circumstances. So normal walking, for example, also walking when copying the gait pattern of someone else, in this case, a person walking in front of him on the video screen. By comparing the normal condition with those conditions in which compensation strategies are applied, we hope to unravel how the control of gait is being changed. The second, I think, exciting idea development relates to freezing and the levodopa paradox. So we know that freezing typically responds well to dopaminergic medication, and levodopa in particular, but there are also observations that freezing of gait is nowadays more common compared to the days before the introduction of levodopa in the 60s of the previous century. So this suggests that levodopa might be a double-edged sword. So on the one hand, it helps to reduce freezing of gait, but it might also be involved in making the gait network more vulnerable to develop freezing of gait. Well, this is still a very provocative hypothesis, and I'm currently studying this by comparing a cohort of people in the Netherlands with Parkinson's disease and who have received levodopa for many years, with people with Parkinson's disease in sub-Saharan Africa and in Brazil, where they do not receive levodopa, as this is too expensive or not available. And if this hypothesis is true, I would expect to see that freezing of gait in Brazil and sub-Saharan Africa is less common compared to the Netherlands. And importantly, this is not to say that people should stop using levodopa. It has many good effects. The symptoms are less severe. But if this is the case, we need to think whether we need to adjust the administration, for example. Well, finally, and this is the third exciting development, and this is actually the holy grail of freezing of gait management. So you would like to have on-demand therapy. So knowing that freezing is due to a disorder of the network that controls gait, you would like to measure when someone is at risk of developing freezing. And this can be, for example, be done using EEG or possibly using new DBS leads, deep brain stimulation leads. And when someone starts to freeze, you would like to apply on-demand therapy. So adjust the DBS settings immediately, or apply on-demand compensation strategies, for example, using laser shoes or using vibrating socks, which we have currently developed, but we cannot apply them yet on demand, and hopefully we can do so in the next 5 to 10 years. Thank you very much for your attention, and looking forward to your questions later on. Thank you.